Most parents, particularly mothers, worry that their child is going to be born with some sort of birth defect. And the most common birth defect is cleft lip, cleft palate. Arguably, some would say club foot is equal to cleft lip and palate. The frequency varies according to ethnic groups. As a general number, it's about 1 in 700. It's more common in Asians and far less common in African American children. Clefting occurs in the first trimester. Cleft lip occurs around 4 to 6 weeks of intrauterine life. That's when the lip segments and the nose come together. Cleft palate occurs a little later, around 8 to 12 weeks of intrauterine life.
Cleft lip and cleft palate can occur separately or they can occur together. So you can have patients with an isolated cleft lip, you can have a patient with an isolated cleft palate, or you can have a patient with a cleft lip and a cleft palate. So they do not have to occur together. The cleft lip is really only similar to the cleft palate in the sense that it also is a failure of fusion. So portions of our lip in utero usually fuse, and that completes the lip. With a cleft lip, those two elements of the lip don't fuse and you have that opening. And so again, my job as a surgeon is to repair that, and it's a 3-layered closure. So you're repairing the outside skin, the inner muscle, and the mucosa on the inside of the lip, which is the inner lining of the lip. Generally, the palate repair is done at maybe 8 to 11 months of age. And the feeling certainly in North America is that people develop speech better if their palate repair is performed before maybe 12 to 18 months.
Well, first both the mother and father have to come to a common ground about accepting the diagnosis of cleft lip and palate. They need to see pictures of other children, and whenever possible, right there in clinic, we usually try to introduce them to another family. Because once they actually see a living, breathing baby that's either been through having a repair of a cleft lip or is in the process of it, it really alleviates a lot of their fears. Feeding is quite different with a cleft lip and palate. Again, most mothers today are prepared to breastfeed. And if there's a cleft of the lip and the palate, breastfeeding may not be possible because the baby will be missing his source of suctioning. And so we may have to assist the baby with feeding. And I usually will plan to meet the parents quite soon after birth, or I'll talk to the obstetric unit and or the newborn nurseries and coach them through how to feed a baby.
If you would read the literature on the psychosocial aspects of children born with cleft lip and palate, you'd almost think it was an advantage to have a cleft lip and palate. Now, of course, it's not in a sense that these kids go through years of clinic visits, multiple operations, seeing all sorts of specialists, and orthodontia, and sometimes major operations when they're teenagers. But on the other hand, I emphasize to the parents, especially in the prenatal visits, that they are very special children. And in general, they're kinder to their friends and to their siblings. They seem to be more sensitive to the feelings of others, and often they work really hard in school because they have something to prove, and I think these kids do terribly well.
You know, given the state of cleft lip and palate management now, it's very likely that they would have a very minimal scar of the lip, possibly almost imperceptible. They could also have very normal speech. So because of the fact that we have the prenatal care and the postnatal multidisciplinary care, the outcomes now are excellent, both cosmetically, functionally, and when I say functionally, I mean both in terms of feeding and speech. So the outcomes now are really outstanding.